I want to do an overview of chapter 13 and 14 with pre and gestational conditions of pregnancy. We first start off in this chapter talking about little specific types. And the first disorder is diabetes mellitus. We do in the book talk about thyroid disorders, but the most one I want you to concentrate on is diabetes mellitus. Also, we're going to talk about cardiovascular as well as substance abuse as well as HIV. Going back over the diabetes, remember we talked about how diabetes, how does it occur, and remember that you may not have enough insulin production or is deficiency in the insulin production. So therefore, when a person is diagnosed, we do need to look at what is the reason behind it and seek some type of nutritional as well as some medicines to lower the blood sugar. And looking at this chapter, page 297 give you a brief overview of why it's important that what we do in checking the actual blood glucose level in the second trimester. Remember, in the first trimester that the insulin need is reduced because of the increased insulin production. And the figure 13-1, it shows you how you have enough insulin production, so therefore you should not need any more insulin. However, in the second trimester, particularly around the 26 weeks, you know that you start having what's called placental hormones, the insulinase and the cortisol, that actually acts as insulin antagonists. Well, the antagonist, it works against, so therefore you need to know you need more insulin. Around the third trimester, insulin requirements gradually increase until about 36 weeks gestation. On the day of delivery, the maternal insulin requirements drop drastically to approach pre-pregnancy levels. Breastfeeding, walking, all that helps, and lowering insulin requirements. If you know anything about diabetes, that's why we encourage people to walk. Also, any type of exercise, because it does help with lowering your insulin needs. Going to look at some of the metabolic changes of pregnancy, when you read there and just look at how the effects, I talked about it right here on page 297, but also in your reading you'll see that as well. We talk about type 1 and type 2. Remember, type 1 is insulin dependent. Type 2 is what we call, you may have insulin but not enough to make. You have other specific types caused by infection or drug induced. Gestational diabetes mellitus is any degree of glucose intolerance with onset of recognition during pregnancy. So anytime you get it, whether you are already diabetic or anytime you develop it, we call it gestational diabetes. One of the things we need to make sure of that they know about different complications, and the major thing is ketoacidosis, which we have talked about that in length, as well as hypoglycemia. Remember, what ketoacidosis happens is that they don't have enough glucose to use up, so they start burning ketones, and those start spilling because they naturally should not be spilling in the urine, but because they cannot reabsorb them, they start spilling in the urine. As well as hypoglycemia, that means when you have a low blood glucose level, and that can be deadly. Here again, this is the actual figure 13-1 that I was talking about. Please make sure you understand this and the insulin needs. We also talk about pregestational diabetes mellitus. That means you already had diabetes, and when you were already pregnant. We talk about preconception counseling. That means which is recommended by all American Diabetes Association, because we want to make sure they know that, again, what kind of impact that your body has, or the baby being pregnant will have on the mom's body. Some of the fetal and neonatal risks are sudden and unexplained stillbirth. We don't want it to happen. That's why they're going to be under heavy surveillance. Like if they are already diabetic or they already have some type of medical problem, pretty much they're going to go to a specialist. You also can have some type of congenital anomalies, central nervous system, cardiac defects, skeletal defects, and other problems. It's very important for you to read that. We talk about the assessment. Remember, a past glycemic control. We want to make sure how they're doing if they already are diabetic. We want to, first of all, they would do something called a fasting blood glucose level. Remember, I told you between 24 and 28 weeks, and that's to diagnose. But to maintain control, we always do what's called a hemoglobin A1C. This lets us know how well they are maintaining. Here in your page 299, it tells you about assessment of past glycemic control for any woman with pregestational type 1 or type 2. The glycolated hemoglobin A1C level may be measured, and you want it really to be lower than, usually between 6 and 7, or 6 and 8 means good control. It means good control. Well, excuse me, they say 5 and 6 in your book is the desired goal, which relates to an average of 90 to 120 milligrams per deciliter. We also tell them antepartum-wise how to exercise. We tell them about the insulin therapy, how to give it. Remember how you draw up between, if you have to have 2 types of insulin, cloudy and clear, make sure you always draw up the regular first, but you put air in the NPH first. We tell them about fetal surveillance. They're going to monitor the baby because we do know the incidence of having what? Again, polyhydramnios, a lot of amniotic fluid. We know that anytime they get sick, it will impact their blood glucose level, so that may require them to go to the hospital, as well as any other types of infection or any other type of problems. Determination of birthday and mode of birth, because again, these are normally big babies, so we need to make sure she knows there's possibility of having a C-section. And family planning, contraception, because it's very important, because remember, diabetes alone is a multi-system disorder. It just doesn't affect your endocrine system, it affects your heart, your vascular system as well. So we want to make sure they know that, your body just went through a whole lot of changes with pregnancy, especially if you were already diabetic and became pregnant. We want to make sure you wait before you have any more children. We talk about gestational diabetes. It's also maternal and fetal risk if you become diabetic while pregnant, as well as doing the diet and exercise, and then monitor your blood glucose level. It shows you here in the book, starting on page 301, about what is the target blood glucose level. They say fasting, like if I was to wake up, and especially like over 6 to 8 hours, I should have a reading between 60 to 90. Pre-meal, like before lunch and dinner, between 60 and 105. Bedtime, usually again between at 90 and 120. An hour after your post-meal, you should go from between 100 to 120. 2 hours after 90 to 120, then 2 a.m. to 4 a.m., 60 to 120. So it's very important for them to know the different blood glucose reading. We did not go over thyroid, however, just be aware, because people can have thyroid disease and become pregnant. Cardiovascular, remember you have increase in intravascular volume, decreased systemic vascular resistance, so you shouldn't have much resistance, so you have more volume. Cardiac output changes during labor and birth, intravascular volume changes that occur just after birth. Now, with disorders, increased incidence of miscarriage, because again, anytime you put more workload on the heart, there's more problems with them having to carry the baby full term. Preterm labor, because again, if she already has some type of heart defect, this would put a lot more pressure on her heart, so she can't carry the baby to full term. Intrauterine growth restriction, and that's really abbreviated IUGR. It's most common. The incidence of congenital heart lesions increase in children or mothers with congenital heart disease because probably of the genetic effects. There are different types of different disorders that are listed, but I only concentrated or hone in on 2 of them, and make sure you know that. The Ensmerger's syndrome is the right and left, or the bidirectional shunting that can be at the atrial or ventricular level and combined with elevated pulmonary vascular resistance. This syndrome is associated with mortality rate of about 50% during pregnancy. Thus, pregnancy is contraindicated, so they don't want you to really get pregnant. If you continue with the pregnancy, despite the risk, physical activity is limited. Prophylactic anticoagulation is considered. And remember, if you're going to do anticoagulation therapy, it has to be heparin, because warfarin, Coumadin crosses the placenta. Also, they say intensive care monitoring, so these people probably be on either bed rest at home or have to be in the hospital for a great deal of time. A team approach involving the perinatologist, because again, the baby's going to be probably born fairly early, as well as cardiology and other skilled critical care team. The next one is Marfan syndrome, and this is an autosomal dominant gene disorder characterized by generalized weakness of the connective tissue, resulting in joint deformities, ocular lens dislocation, and weakness of the aortic wall and root. About 90% of individuals with this syndrome have MFVP, mitral valve prolapse, and 25% have aortic insufficiency and have an increased risk of aortic dissection and rupture during pregnancy. They can have excruciating chest pain, this states. So mostly the therapy includes limiting physical activity, both of them limited physical activity, preventing hypertensive or hypotension complications, administering your beta blockers, and those are listed in the book. Aortic root measurements were taken early in pregnancy as a baseline, and then intervals to detect increasing diameters, and preconception and genetic counseling are recommended to make women aware of the risk, because again, you don't want them to go in there not knowing what some of the risks are of trying to continue to have this baby. They do talk about heart transplantation, but we didn't get into that. Increasing number of heart recipients are successfully completing pregnancies before conception. Women must be assessed for quality of ventricular function. I didn't really go over that, but just let you know, if you ever see this again, yes, just because they had a heart transplant doesn't mean they cannot get pregnant. Here, when we talk about anytime anticoagulant therapy, heparin, large molecule drug, does not cross the placenta, so that will be used. We normally, again, Coumadin is one of the ones that we give PO, but remember, they have to stay on heparin. Cardiopulmonary resuscitation of a pregnant woman. This is what cardiac arrest, standard recessive efforts with few modifications are implemented. Again, if you're going to have to defibrillate, paddles must be placed one rib interspace higher than usual. You always do, when every time you do something to the mother, you always monitor the fetus and the heart rate, because this let us know if the baby is actually getting oxygenation. If you go to page 314, remember that little box up there, a table about normal signs and symptoms that you should see cardiovascular-wise and what would mean abnormal. So make sure you take a look at that, as well as what we mean by decompensation. And anemia, yes, we know it happens, as well as iron deficiency. You may have a folic acid deficiency anemia, and would you just assess the reason why they have these types of anemia? They're not taking enough in their diet, or the ones they take is not getting absorbed. But with sickle cell, we know that there is a hereditary factor here. And yes, we try to go with preconception counseling, because what you want to do is tell her the risk involved if she choose to get pregnant, what would toll on her body. It makes you know about sickle cell. Remember, this is presence of normal hemoglobin in the blood. And what it is, it's a sickle shape, and instead of the round donut shape, it's sickle, and it clumps together. Here on page 323, it tells you about some of the potential problems that occur, because remember, if this is your oxygen component of the blood, and if it's not fully shaped, it's not going to give you much oxygen, so they're going to have an inability or inadequate oxygen to meet their needs. So they may have to have oxygen, may have to have transfusions. Also administer oxygen continuously during labor, because remember, if she doesn't have oxygen, the baby's not going to either. Infection, you need to watch that because of decrease in their hemoglobin, and also sometimes their white blood cell count. Sequestration crisis, this is caused by the need for and destruction of RBCs. You want to administer a folic acid supplement and decrease erythropoietic demands and reduce the probability of capillary stasis. Crisis caused by hypoxia or hypertension, acidosis. It tells you to continue as number one. That means giving them the hemoglobin and monitoring their levels. Have type and cross-match blood available. Assist with transfusion, as well as give them oxygen. When talking about HIV and AIDS, preconception counseling is very important because, again, what you need to tell them is it is a risk of the baby being actually, the mom actually transferring HIV to the baby. However, it's decreased the risk once she takes some antiviral drugs, so we want to get her started on that as much as possible. It's difficult to determine the obstetric risk of a person with HIV because so many confounding variables are often present. A lot of these people, if they have HIV, and again, we're not classifying all people, but they may have some underlying drug problems, some other type of conditions that would superimpose them to other types of infection. So you got to look at the whole person, because just because you say, well, could be a well-educated, well-nutritious person, then they're going to have a more decreased risk of having any complication than someone who was already strung out on drugs or anything like that. Mother-to-child transmission, this is one of the modes of transmission. And we want to look at obstetric complications. Now, again, if she doesn't have any complication, it will decrease the risk of the baby having. We know that they should be treated highly with an active antiretroviral therapy, which is called HAART, during pregnancy. They also always be treated for other sexually transmitted disease, because normally they don't just catch HIV, they have some other STDs as well. Opportunistic infections, that means that because of the decreased immune system, they are anywhere around somebody with a cold or whatever type of infection, they may catch it as well. And every effort should be made to decrease neonates' exposure to bloods and secretions. That's why they recommend kind of like go ahead and doing a C-section. Immediately after birth, infants should be right free of all body fluids, and then bathe. All staff working with mom and infant must adhere strictly to infection control techniques. One of the things I just tell people, the ones who are already HIV positive. It's the ones you don't know. That's the ones you got to be careful of. So I treat everybody the same, making sure I observe standard precaution for blood and other body fluids. Substance abuse, they should not take any medication unless it's prescribed, and that's why we tell them about anything for us like smoking, alcohol, any other type of substance like heroin or cocaine, because what that happens, they superimpose them to like bleeding complications, miscarriage, stillbirth, or baby born premature with some other congenital defects. Also, they have a low birth weight baby and sudden infant death syndrome. So we tell them, unless the doctor has prescribed it, don't take it. This was just an overview again of Chapter 13. Make sure you pay close attention to all the information, as well as reading your chapters, as well as answering some of the questions in the back. We're going to start now with Chapter 14, Pregnancy at Risk and Gestational Conditions. And again, I went over most of this in class, but I can't stress enough for you to go back to your key points at the end of the chapter, as well as looking along with your book, your study guide book. The biggest thing that start off in Chapter 14 is talking about your hypertension in pregnancy. We also talk about hyperemesis gravidarum, hemorrhagic complications, surgery, trauma, and STDs. Here, when you talk about hypertension, you need to find out, first of all, when did the hypertension occur? What's their normal blood pressure? What other symptoms have they been having? Because, remember, we classify them as having PIH when they have the hypertension, along with the proteinuria, and along with the edema. Now, like I used, for example, this morning, you can have edema or proteinuria without having high blood pressure and other disorders. But in order to have PIH, you have to have the high blood pressure. We know that it does increase the risk of morbidity and mortality, and so therefore we need to make sure that we are monitoring her closely. That means that you have to do a thorough assessment and making sure you pick the right arm, and making sure you assess the blood pressure accurately, and make sure you're watching her weight, as well as watching her urine when she comes in. And again, if you get abnormal reading, see if you lie down and see if the patient can lie down, and see does that lower the blood pressure. But then again, you want to monitor at a different time of day and see if it's still elevated as well. Remember, we classify this as a blood pressure greater than 140 millimeters of mercury, or diastolic greater than 90. And you have to have 2 measurements that meet the criteria for gestational blood pressure elevation. When you're talking about gestational hypertension, onset of hypertension during pregnancy or at the 24 hours after birth. So that's what we're talking about, and usually after 20 weeks. Preeclampsia is your pregnancy-specific syndrome, and it develops after 20 weeks, and disease reduces the organ perfusion, because what happens is you call vasospasm, and so therefore enough blood is going to the vital organs. Here, when you're talking about severe preeclampsia, and again in your book, it kind of breaks down when you go into mild preeclampsia to severe preeclampsia, and you need to know the difference. Anytime you hit greater than 160 or greater than 110 diastolic, that means that you are in more severe preeclampsia, and you need to know about cerebral disturbances. Ask them, are they having dizziness, spots before their eyes, blurred vision, anything like that, headaches, unexplained headaches. And eclampsia, of course, is when they get to a seizure activity. Chronic hypertension, again, if you look at the bottom of page, right here on page 335, it tells you about when you talk about chronic hypertension, that's diagnosed before 20 weeks of gestation. Etiology, the symptoms develop only during pregnancy, and birth is the cure. And we talked about that. Talk about the risk factors, the primal gravity, multifetal pregnancy, if you are already obese or you're above the age, before the age of 20 and after the age of 40. And the main pathogenic factor is not an increase in blood pressure, but poor perfusion resulting from vasospasm, because it takes more effort to get that blood flow, and the arteriolar vasospasm diminishes diameter of blood vessels, which impedes blood flow to all organs. And we know we're talking about even the placenta, kidney, and liver, and brain is depressed as much as 40 to 60%. We also have to look at other complications that can be associated as well with preeclampsia, and that is our HELLP syndrome. If you look here on page 338, it talks about the laboratory diagnosis, and this is not made by visual, this is made by laboratory. That's when you have hemolysis, you have a breakdown of red blood cells and elevated liver enzyme, as well as low platelets. Remember I told you about the norm for platelets. And pretty much what they'll come in and make sure is she not having any swelling of the liver. So a lot of times the doctor will go and assess and say, let me feel your right side and make sure it's not swollen or anything like that, and make sure she's not having any epigastric pain. So remember, this is diagnosed HELLP through laboratory. Your nursing management for your HELLP syndrome is pretty much you want to monitor and make sure you observe their platelet count as well. In our interview, when we're doing our assessment with our patient, you can look and see if the person having any swelling, dependent edema. That means like when you mash it in, it stays, and like pitting edema. Look at the deep tendon reflexes and see if they have any problems there. Also, you look at the laboratory tests again, your platelet count, your RBCs, and see what's going on there as well. Here on page 341, it tells you about your assessing your deep tendon reflexes. This is especially important, especially when you're doing the mag sulfate, because it does cause decreased deep tendon reflexes. But you want to check these as a baseline to check any changes. Because remember, once they start having more severe PIH, that's when we're going to introduce them to the mag. So you want to get a baseline first before you start the mag. Here showing you about the actual pitting edema. If you look on page 341, it shows you like how it should be indented. Like +1 is like at 2, but +4 is like at 8 millimeters. Again, if it's just mild, we're going to try to treat with home care and also activity restrictions. And again, what we're going to do is put them on strict break, put them on bed rest. That means they can't get up. And one of the things we notice with bed rest, a lot of times people say, oh, I enjoy bed rest, but it has a lot of psychological problems or psychological implications with it. You laying down all day, and after a while you get tired of watching the same show or doing the same thing every day, and you can't get up and you feel kind of vulnerable. I know when I was on bed rest, that's one of the things that I felt like everybody else was able to go and I wasn't. Diet should consist of no added salt. So we want to make sure diets high in protein and low in salt have been suggested to prevent preeclampsia. Not really a lot proven, but we want to make sure they have adequate fluid intake to help maintain optimum fluid level. So it's pretty much if the woman does what she's supposed to. And if you look at guidelines on page 343, it tells you about different well-balanced diet. We also talk about severe preeclampsia and development of HELLP syndrome. They're probably going to have to go to the hospital, and therefore we'll monitor them there. Again, if we notice, and you'll learn this more when you get to Unit 2, if we know the woman is pretty much keep on having elevation of blood pressure, yes, we're going to treat her with max sulfate because it is a tocolytic. That means it's going to stop her from having contractions, as well as help with the possibility if she has convulsions. But one thing we want to do is we want to make sure that we go ahead and prep her possibly for go ahead to have a delivery. So if she's like preterm, and again, we'll talk about this in Unit 2, it's not uncommon for them to go ahead and administer like betamethasone or dextromethasone, because those are surfactants that we can give to help the baby's lung mature. Those are, glucocorticoids, that these can actually, antenatal glucocorticoids, that can actually speed up the development of those pulmonary surfactants. So that won't be surprising. With mag sulfate, it tells you at the bottom, it's very important for you to know about mag sulfate. While we administer it, it's always on a pump. It tells you about the dose and usually your potassium levels. And remember those levels, okay? Also, whenever time you give mag sulfate, remember, whatever you give, you need to always have an antidote for it, because if it causes respiratory depression, one of the things you want to be concerned about is they're not having any type of actual problems breathing. So calcium gluconate is the actual antidote for our magnesium sulfate. Chronic hypertension, again, it can lead to PIH as well as severe preeclampsia as well as eclampsia. So it just tells you about how it's done there. Going back, it tells you about some of the antihypertensive drugs, and you need to be aware of those as well, like the meledopia, that's like your Aldamet, and also your hydrozoline, that's your Presaline. These are some medications that we give and why we give them, so make sure you know those on page 348, those different medications. Hyperemesis gravidarum, that means you have too much vomiting, which results in electrolyte imbalance. So mostly what we try to do is make sure that if they start vomiting and they can't stop, they go to the emergency room where they may have to get an IV. And mostly they just monitor them and try to keep them from like eating at the present, and then eventually they start doing a clear liquid diet, then a soft diet or whatever. But pretty much your major thing you're worried about is electrolyte imbalance and ketosis, and you want to make sure you monitor that. Hemorrhagic disorders, remember we talked about early and late bleeding. Our early ones was mostly dealing with ectopic pregnancy or miscarriages or abortion and hydeniform mold. You need to know each one when they occur, the signs and symptoms, as well as what is the treatment. When you're dealing with a miscarriage, it all depends on the type and what clinical manifestations is happening. But again, if we check her RH factor and she is negative, remember we're going to have to go ahead and give her RhoGAM if we find out she's RH negative. For incompetent cervix, we know we talked about that. That is like a way that we can actually go in and kind of, and this just by how they do it is stitch up the cervix. It's called a cerclage, because what's happening, the cervix is actually dilating and we want to close it up. Ectopic pregnancy, we know it most occur in the tubes, but it can occur other places as well. So pretty much, again, we want it to pass. If it does pass, we'll make sure that if she's RH negative, give her RhoGAM. Make sure you understand, again, like with abortion, ectopic pregnancy, and this next one, hydeniform mold, make sure you know the signs and symptoms. Late bleeding, placenta previa and eruptive placenta, make sure you know the difference and how it occurs. Placenta previa is when the implanted placenta implanted in the lower uterine segment near or over the internal os, where the ruptured placenta is tearing away from the from the uterine wall. So again, with placenta previa, do you have pain? No, but you have bright red bleeding. With a ruptured placenta, you have dark red bleeding and pain. We talked about clotting disorders. When we get into this again, you'll learn this, especially in high-risk pregnancy, when we start talking about like DIC. Remember, the coagulation process involves interaction with coagulation factors, in which factors subsequently activate the next factor in line. Like one used up, then it triggers 2, 3, 4, and 5. And we talked about DIC, and this is pathologic form or diffuse clotting causes widespread external and internal bleeding. Like you start using up all your clotting factors and you bleed everywhere. Trauma during pregnancy, it can occur. First off, we got to find out, what happened, like what organ or what was involved. Did she fall? Did she have any pain? Does she have any bleeding? Monitor the baby. What's the main thing we're going to focus in on? That heart rate. And remember, we need to make sure we take care of her, because her survival impacts the baby's survival. Also, we know it's influenced by length of gestation, type of severity of trauma, and degree of disruption of uterine and fetal physiological features. It tells you here, requires strategies adapted for appropriate resuscitation. We'll look at the uterus and bladder position, elevated levels of progesterone, decreased tolerance for hypoxia and apnea, cardiac output, and circulated blood volume. These are just a quick overview. Make sure you pay close attention to the medications that are in this chapter, as well as especially like with mag sulfate and some of the blood pressure medications. Hope this helped. Study hard.